Evening, chairpersons and delegates. It's my pleasure to talk today on Anomalous Coronary PCI, the challenges. So Anomalous Coronary Primary PCI can be time-consuming, technically demanding, involves more fluoroscopic time, it involves more contrast load, and it also delays the reperfusion. Origin is uncommon. It's occurring in about 0.2 to 1.2% of patients. And they are grouped under four major subtypes: anomalies of origin and course, intrinsic anomalies, anomalies of termination, and anomalous anastomotic vessels. One of the important challenges which we face often is right coronary artery arising from the left sinus of Valsalva, which has been reported about 6 to 27% of patients with coronary artery anomalies, and this forms a more challenging scenario. And this is an algorithm which says if it is above the left coronary sinus, you can use a JL. If it is on the same level as the left coronary, you use an EBU or XB. And if it is below, an AL1 or 2 is preferable. So having some algorithms is quite helpful. This is a very elegant pictorial diagram which illustrates various anomalous origins and which catheters you can use, and it is useful to have it on your cath lab. But most of the time what we get away with using the Judkins, Amplath's right, left, and the XB or EBU. The other catheters we seldom use. So most of these cases can be managed with the available standard catheters. So I'll show a few case examples of what challenges were faced and how I encountered them. A 42-year-old male with uncontrolled hypertension on non-compliant on medications and with a hemoglobin of 9.6. He came with a blood pressure of 190/110. His EF was 50% and an inferior wall MI. His left system did not have any critical disease. His right system, a little anomalous origin high up in the non-coronary sinus, a tortuous anatomy and distal total occlusion. And if you can see, there is a distal calcium chunk which is in the bend. So this was the challenge in this patient. Initially, I took this patient, I've done a radial approach. So initially I took a JR4, and JR4 did not give any support to get the wire across. So switched to an AR1, and with this I could get across to the distal vessel, and there was TIMI3 flow. At this point, the patient developed hypotension, brady. He was in 70/40 BP, started on NORAD. And I thought I would just dilate with serial balloons and then fix the lesion. But even a 2N balloon wouldn't cross the lesion. The proximal chunk of calcium was preventing it. So I went serially with a 1.5 balloon and then subsequently a 2 balloon. And then a 2.75 and a 3 balloon. But even then could not deliver the stent. The proximal lesion was not giving way. So here I had to switch to a AL 0.75 for better support and use a guide extension catheter as well, and delivered a cutting balloon for the proximal chunk of calcium. But you can see that even there was dog boning even with a cutting balloon, and could not deliver the stent even with a cutting balloon. So the next option was only an IVL, and IVL took it up to 80 pulses, and with the final pulse, you can see that the dog boning disappears, and the patient could be delivered with two stents, a 2.75 23 des distally and a 3.5 33 proximally, all with a guideliner support. And the patient stabilized with a mild support of NORAD, and his ST resolved. So if the patient has an anomalous coronary, you can get away if it's a simple lesion with partial support, but if the lesion is complex, you need adequate support. So this is another patient with non-STEMI, post-op CABG. So I took through the right femoral root. He had a critical LCX lesion, native lesion, and the lemur was patent, and his RCA graft was also patent. So the plan was to go ahead with an LCX plasty, but even after attempting almost 6 change of catheters, AL1, AL2, XB, EBU, everything I tried, JL, but could not cannulate. And by this time, the patient also had hypotension 70 and some drop in hemoglobin. A check angio of the femorals did not reveal any anomalies. Check echo was also normal, but I was a bit worried. So I took him off the table, brought him back after a couple of hours, studying that he was stable now through the radial. And with an XB4, I could easily cannulate within 2 minutes. So switching from femoral to radial sometimes helps, especially when the patient has a dilated aortic root and tortuous aorta, it can help you. And serial dilatation, being a calcific lesion, was done. Then with a guideliner support, delivered the stent. There was some peri-stent staining. So this is an indication that if you go any further, you may rupture the vessel. So I stopped here and accepted the result. And the patient did well clinically, and on follow-up 3 months, he has no problems. So this is another case where the inferior wall MI with anomalous RCA. The RCA could not be cannulated from the right sinus. Non-specific shoot shows that with the pigtail shows that it is arising from the left sinus, almost at the same origin as the left coronary artery. So the RCA was cannulated with an XB3, turning it towards, from the left system, turning it towards the right. You can cannulate with an XB3. Sometimes anomalous coronaries can be a blessing as well. This is a patient with an anterior wall MI with ongoing chest pain. And you can see that the LCX only is seen. I thought maybe faintly filling distally LAD with TIMI-1 perfusion. I thought it could be an ostial flush occlusion. Check the RCA, and it is retrograding from RCA up to the proximal level. The other possibility was that it is a short left main. So I cannulated the LCX and then wired it and then pulled it back a little bit. And then you can see that there is a LAD which is separate origin from the LCX. So switch the catheter to JL and cannulated selectively the LAD. And now it is quite straightforward, and you don't have to worry about the spill of the thrombus into the LCX, and it is quite straightforward plasty. So this is another case with anomalous origin. You have an LCX originating from the right coronary artery. And here, cannulation with an RCA is only cannulating the regular RCA. So here what we did was just pull back the RCA, airmail the wire into the LCX, and then used a guidezilla. So once you use the guidezilla, you have stability and you can complete the angioplasty. This is not my case. This is a report from Srinagar in India. A primary PCI, when it was very difficult to cannulate, only with the diagnostic catheter in this kind of a loop, it was cannulated. So they did not want to waste time when the patient was having ongoing chest pain, and completed the PTCA with the diagnostic catheter. And this is quite possible. If it is a very simple angioplasty, you can complete it even with a diagnostic catheter in dire situations. Thank you.